Welcome to Bookfulness. This is your essential shortcut to clinical mastery, diving deep into the most complex structures of human anatomy.
And we are on episode 34 of our series, drawing all of our material from the latest clinically oriented anatomy texts.
In the previous deep dive, we spent a good amount of time on the architecture of the face and scalp, and we focused pretty heavily on those protective elements, specifically the meninges.
Exactly. We identified them as that crucial set of layers separating the skull from the brain tissue itself.
So today, we're picking up right there. We are, metaphorically speaking, peeling back the dura.
We are.
Our mission is to take an exhaustive look at the brain. We'll cover its protective scaffolding, its vital fluid systems, and that incredible and often vulnerable vascular network that feeds it.
And then from there, we'll zoom right in on the orbits, the eyeballs, and all the intricate machinery that's responsible for sight.
This deep dive is really all about understanding both the resilience and the critical weaknesses of the central nervous system and its accessory visual structures.
Okay, so let's unpack this. We often think of the cranium as the main protection for the brain.
Right, the hard shell.
But really, the three-layered meningeal envelope is the immediate barrier and, I guess, stabilizer. So we've talked about the dura mater before, that tough outermost layer. Why does its structure matter so much from a clinical perspective?
Well, it all comes down to failure mechanisms. When we start talking about trauma, where blood pools is entirely determined by these layers, the dura mater is this tough, thick, external fibrous layer. You'll sometimes hear it called the pachymeninx.
Right.
And in the cranium, it's unique. It has two layers. You've got the external peristeel layer, which adheres really tightly to the bone, and then the internal meningeal layer.
And the space between those two layers, or at least the potential for a space to form, that's what's key when we're thinking about hemorrhage. Precisely. The meningeal layer is what we call the sustentacular or supporting layer. It actually reflects inward on itself.
And that forms partitions, right?
Exactly, like the false cerebri.
Yeah.
And that provides this incredible internal support for the major parts of the brain. You know, the cerebrum, the cerebellum, and the brainstem. Those are the big components we're focusing on today.
So moving inward from the dura, we hit the leptomeninx, the more delicate inner layers, the arachnoid and the pia mater. What really defines these two?
So the arachnoid is the intermediate one. It's kind of wispy, and it's avascular, meaning it has no blood vessels.
Okay.
And then the pia mater is the innermost layer. It's incredibly delicate and highly vascularized, and it follows every single contour, every groove of the brain tissue, almost like shrink wrap.
And together they're called the leptomeninx.
The slender membranes, yeah.
So the critical space, the subarachnoid space, lies right between them. This is where we find the brain's buoyancy system, isn't it?
That is absolutely right. The brain, it weighs on average about 3 pounds.
It's heavy.
It is, but it feels almost weightless inside the skull. And that's because it's suspended in cerebrospinal fluid, or CSF.
And how is it suspended?
Well, it's thanks to these numerous web-like filaments called arachnoid trabeculae. They literally anchor the brain to that protective arachnoid layer above it, holding it buoyant within the fluid.
Interesting.
And the arachnoid itself isn't actually attached to the dura. It's just held up against it by the pressure of the CSF underneath.
Let's focus on that CSF system then. It's not just water, right? It's this plasma-like fluid that has multiple functions.
It's a critical, clear fluid. It's somewhat similar to blood plasma, but it has very specific protein and ion concentrations that are optimized for neural health.
And where is it made?
It's continuously manufactured by these specialized capillary networks called choroid plexuses. You find them inside the 4 ventricles of the brain, the 2 large lateral ventricles, the 3rd ventricle, and the 4th ventricle.
Okay, so CSF forms inside the ventricles, it circulates through that system, and then it has to get out of the ventricular system to enter that cushioning subarachnoid space that surrounds the whole brain and spinal cord. What's the fundamental function of all that circulation?
Well, beyond the immediate cushioning effect, it acts as a hydraulic shock absorber, which is essential during sudden head movements. It's crucial for metabolic function.
Oh, so?
It nourishes the brain, it carries away waste, and critically, it helps maintain the overall extracellular fluid balance of the neural tissue. This entire system produces something like 500 milliliters of CSF every day.
Wow.
Which means the fluid is completely replaced 3 to 4 times a day. It's a constant cycle.
If it's being produced that constantly, there has to be an equally efficient way of draining it. Otherwise, the pressure would build up incredibly fast. So how does this fluid get back into the bloodstream?
This is handled by a really remarkable structure. They're called the arachnoid granulations, or villi. Imagine them as these little tufted prolongations of the arachnoid that poke right through the dura mater and project into the low-pressure drainage network of the dural venous sinuses.
Particularly into those lateral lacunae that flank the superior sagittal sinus.
Exactly.
So they're basically one-way valves. They ensure that CSF moves from the higher pressure subarachnoid space into the low pressure venous blood.
And that maintains that really delicate homeostatic pressure balance. If these granulations get blocked or they're just not sufficient, we run into conditions like communicating hydrocephalus.
Right.
And a failure of reabsorption means increased intracranial pressure, which is a neurological emergency. It impacts literally all the structures we're discussing today.
Okay, shifting our focus back to the hard protective shell for a moment, the cranium. The bone itself isn't uniformly strong, is it? We have these specialized load-bearing structures called cranial buttresses.
Yeah, you can think of the cranium like a specialized helmet. It has weaker areas, primarily the orbits and the nasal cavity, which are essentially holes. The buttresses are thickened portions of cranial bone designed specifically to bypass these fragile regions when an impact occurs. They're the structural pillars that transmit the force.
What are the primary examples of these force transmission pathways?
Well, you have the front nasal buttress, which runs vertically, and it carries forces from, say, the teeth, bypassing the nasal cavity, up to the frontal bone.
Okay.
Then you have the zygomatic arched lateral orbital margin buttress, that's the lateral pillar, and it transmits force from the molar region outward to the temporal and frontal bones. They're incredibly efficient in diverting compressive forces away from the soft tissues of the eyes and the sinuses.
But despite the sort of ingenious engineering, there is one specific point of failure that is, well, it's famous, or maybe infamous, in clinical medicine, the Fallerian.
Ah, the apterian. It is the textbook example of vulnerability. It's that spot on the lateral aspect of the skull where four major bones, the frontal, parietal, the greater wing of the sphenoid, and the temporal bone, all come together in an H-shaped suture pattern.
And it's very thin.
It's incredibly thin, almost like tissue paper. You can locate it roughly 2 fingers breadth superior to the zygomatic arch.
So why is a fracture at this specific, seemingly small point so catastrophic?
It's because of what lies immediately deep to it. The parprion overlies the frontal branch of the middle meningeal artery. This artery travels between the dura mater and the bone. So a traumatic blow, even a moderate one, can fracture that thin bone and immediately rupture the artery.
And since it's an artery, the bleeding is going to be rapid and voluminous.
Exactly. It creates a rapidly expanding mass of blood, what we call an epidural or extradural hematoma. The dura is normally tightly attached to the bone, but this arterial blood pressure just strips the dura away from the calvaria.
And that pressure buildup is the emergency.
Given the speed of arterial bleeding, the pressure buildup on the underlying cerebral cortex can lead to herniation, unconsciousness, and death within hours if it's not treated. This is why a fracture at the septerion is an immediate, life-threatening neurological emergency. And if we connect that urgency to the bigger picture, the vascular architecture of the brain, both its arterial supply and its unique venous drainage, that really determines the severity and the pattern of nearly all neurological events.
Whether they're trauma-induced or stroke-related.
Exactly.
So let's start with that unique drainage system. Instead of typical veins, the brain relies on these specialized channels within the dura, the dural venous sinuses.
Right. These sinuses are endothelium-lined spaces that are situated right between the two layers of the dura mater. They act as these large collecting vessels, and they receive the large veins from the brain surface.
And they don't have valves, which is a key difference.
A huge difference. Unlike typical veins, they lack valves, and that has profound clinical consequences, especially when we talk about the spread of infection later on.
Okay, so the largest one is the superior sagittal sinus.
Correct. It runs right along the attached border of the falx cerebri, and it receives blood from the superior cerebral veins. Eventually, most of the drainage from all the sinuses converges posteriorly at a point called the confluence of sinuses.
And from there, it heads towards the internal jugular veins.
That's right.
We also have to detail the cavernous sinus. This is a structure so complex, it's almost its own little anatomical neighborhood.
The cavernous sinus is absolutely critical. It's located bilaterally on the lateral aspect of the sphenoid body, and it's unique because it acts as a vascular conduit for the internal carotid artery.
Which runs directly through it.
Directly through it, surrounded by sympathetic nerve fibers.
What else makes it such a nexus of activity?
Well, several crucial cranial nerves run either through the sinus itself, like CNVI, or they're embedded in its thick lateral wall. That would be CN-talon-ther, CNIV, and branches V1 and V2 of CNV. The fact that the internal carotid passes through it is fascinating, but its venous connections are perhaps even more clinically significant, especially the fact that it receives drainage from the superior ophthalmic vein.
And that connects directly to the arterial supply coming up from the neck. The brain gets its blood from two major paired arteries.
Right, the internal carotid arteries, or ICAs,
Yeah.
and the vertebral arteries. The ICAs ascend through the neck without giving off any named branches, which is a key identification point in the neck, and they enter the cranium via the carotid canals to supply the majority of the cerebrum and the structures in the orbits.
The vertebral arteries, on the other hand, they have a much more scenic route, and maybe a more hazardous one.
You do. They course superiorly through these bony holes, the foramina transversaria, the upper 6 cervical vertebrae. This tortuosity is usually fine, but in patients with significant arteriosclerosis, this path becomes clinically very important.
How so?
Prolonged and forced neck movements, like aggressively turning your head while backing up a car can, transiently compress these arteries, leading to reduced blood flow to the brainstem.
Which results in that lightheadedness or transient dizziness, a symptom that's often dismissed until it causes a serious fall.
Precisely. And these two systems, the ICAs and the vertebrals, which fuse to form the basilar artery, they meet and they culminate in the most critical anastomosis network in the body, the cerebral arterial circle, or the circle of Willis.
The genius of the circle of Willis is its redundancy. It's meant to ensure collateral circulation if one of the main supply routes is compromised.
It is the ultimate insurance policy. It's formed by the two posterior cerebral arteries, the posterior communicating arteries connecting them to the internal carotids, the anterior cerebral arteries, and then the single anterior communicating artery joining the two anterior cerebrals together.
But like any insurance policy, it often has loopholes, especially in anatomy.
And that is the crucial insight here. Anatomical variations are extremely common, maybe in 1 out of every 3 people. Yeah. You might find an absent or a very small posterior communicating artery or a lacoplastic anterior cerebral artery. These variations are, totally irrelevant in a healthy person.
Right.
But if one of the major feeding arteries is suddenly occluded, the system fails to compensate because the supposed collateral pathway simply isn't large enough to carry the necessary blood volume. The variations can turn a survivable event into a catastrophic one.
That immediately leads us into the clinical reality of all this: intracranial hemorrhage and strokes. So let's revisit the 3 main types of bleeds, starting with the fastest and most dangerous one we touched on, the epidural hemorrhage.
The epidural or extradural hemorrhage is usually arterial. Typically, it's from the middle meningeal branches being torn at the pterion.
Okay.
The blood collects rapidly between the bone and the dura mater. The classic clinical presentation we always teach is immediate trauma, a brief loss of consciousness, followed by a lucid interval that can last minutes to hours.
Where the patient seems fine.
Seems perfectly fine. And then they rapidly deteriorate into drowsiness, herniation, and coma as that massive pressure builds up.
That lucid interval is the key differentiator, and it can tragically mislead observers. Next up, the dural border hematoma, the one that's confusingly called subdural.
Right, this one is different because it's usually venous. It results from the tearing of superior cerebral veins, what we call bridging veins, as they cross the subarachnoid space to empty into the superior sagittal sinus.
And this often follows rapid acceleration or deceleration.
A jerking motion, exactly. It just snaps these delicate veins.
So it's not in a pre-existing space. The slow venous blood pools and actually splits the delicate dural border layer apart. What's the clinical profile look like?
Because it's venous, the collection is much slower. It often takes days or even weeks to accumulate enough pressure to cause symptoms.
And on imaging.
The resulting hematoma on imaging often presents as a crescent shape, conforming to the inner surface of the dura. This slow onset often complicates the diagnosis, especially in the elderly or in alcoholics, where brain atrophy means those veins have farther to stretch and are more vulnerable.
Finally, the subarachnoid hemorrhage. This one's often associated with vascular weaknesses like aneurysms in the circle of Willis.
Correct. Aneurysms are these congenital or acquired weaknesses in the arterial wall, and the high pressure in the cerebral arterial circle makes them incredibly vulnerable. When one ruptures, the blood just violently floods the subarachnoid space, mixing with the CSF.
And what's the hallmark presentation there that demands immediate attention?
The hallmark is the thunderclap headache. Patients describe it as the single most severe headache of their entire life, a sudden onset of excruciating pain.
And what else?
This is usually accompanied by a stiff neck or neutral rigidity, which is caused by the blood irritating the meninges. This is a critical sign of leakage into that CSF pathway.
Speaking of vascular failure, let's detail strokes and infarction. We divide these into ischemic and hemorrhagic.
Right. Ischemic strokes are the vast majority, about 85%. They're caused by an acute blockage, usually from occlusive atherosclerotic disease or a thromboembolism, where a clot travels and lodges in an artery, cutting off the supply downstream.
And the danger is rapid anoxia leading to infarction.
Absolutely. The brain is exquisitely dependent on oxygen. If blood supply is interrupted, brain metabolism shifts within 30 seconds. Neural function is lost within 1 to 2 minutes.
And irreversible damage.
The critical threshold for irreversible damage, cerebral infarction, or dead tissue, is generally considered to be around 5 minutes. And the specific function lost, whether it's motor, sensory, language, depends entirely on the region supplied by the blocked artery.
This is why the concept of time is brain is just paramount in stroke response.
Exactly. And to bring back an earlier point about end arteries, you have to remember the central retinal artery. It supplies the inner retina. If that tiny artery is occluded, there is no collateral flow whatsoever.
So what's the result?
The result is sudden, painless, and permanent blindness in that eye. It perfectly illustrates the absolute criticality of end arteries in the brain's circulation. Every single minute counts when you're trying to restore flow and save the tissue in the ischemic penumbra, which is the surrounding area that's struggling but not yet dead.
Here's where it gets really interesting, I think. Moving from these large-scale protective structures of the brain, let's zoom right in on the orbits. The protected housing for the visual structures, which are themselves just marvels of engineering.
They really are. The orbit is designed as a quadrangular pyramid, and it tapers posteriorly to its apex, which leads to the optic canal. The base, or the orbital margin, is robustly reinforced to withstand direct frontal impacts.
But it's the walls that are the weak spot.
It's the surrounding walls where the real structural weaknesses lie.
We mentioned this vulnerability earlier. How does that asymmetry of wall thickness play out clinically?
Well, the medial and inferior walls are notoriously thin. Paper thin in some regions. This means they are highly susceptible to indirect trauma, specifically a blowout fracture.
Okay.
So if you receive a sharp, blunt blow to the eyeball, say a fist or a squash ball, the reinforced orbital margin holds, but the pressure inside the orbit spikes dramatically.
And that pressure has nowhere to go but down or medially.
Precisely. That pressure forces the thin inferior wall down into the underlying maxillary sinus, or the thin medial wall into the ethmoidal and sphenoidal sinuses.
And the result isn't just a fracture?
No, it's often the prolapse and entrapment of the orbital contents, particularly the extraocular muscles.
Which muscle is typically trapped in an inferior wall fracture?
The inferior rectus muscle is commonly trapped in an inferior blowout fracture. And because the muscle is essentially tethered down in the sinus, the patient loses the ability to elevate that eyeball.
Which leads to double vision.
Vertical diplopia, exactly.
I also noted the superior wall. It's stronger, but it poses a different kind of risk.
The superior wall forms the roof. It's thin enough to be translucent in places, and while it usually withstands blunt force, a sharp object, like a piece of glass or a thin knife, can penetrate it and enter directly into the frontal lobe of the brain, bypassing much of that thick bony protection.
So what exactly is packed inside this protective bursa of fat?
Everything necessary for sight and movement. You've got the eyeball itself, the 7 powerful extraocular muscles, the essential cranial nerves, CN2, 3, 4, 6, and V1 associated vessels, and the orbital fascia. The orbital fat itself acts as this crucial semi-fluid medium that cushions and supports all these structures.
Okay, let's discuss the first line of defense, the eyelids. They're much more than just curtains.
Absolutely. Eyelids are movable folds designed for protection and maintenance. They consist of external thin skin and internally the tarsal plates which provide the fibrous skeleton.
And lining the internal aspect is the conjunctiva.
The transparent mucous membrane called the palpebral conjunctiva, yes.
And that membrane reflects onto the globe itself.
It does. It reflects onto the anterior surface of the eyeball, covering the sclera, the white of the eye, and it becomes the bulbar conjunctiva. This reflection creates the superior and inferior conjunctival fornices, which are these essential recesses where eye drops or foreign bodies can accumulate.
And it stops at the cornea.
Crucially, the bulbar conjunctiva covers the white sclera, but stops abruptly at the periphery of the transparent cornea.
We also have the orbital septum, which serves as a structural barrier.
The orbital septum is a fibrous sheet spanning from the tarsal plates out to the margins of the orbit. Its primary role is to contain the orbital fat and, most importantly, to limit the spread of infections.
So an infection in the eyelid is different from one in the orbit.
Very different. An infection anterior to the septum in the eyelid is usually manageable, but an infection posterior to the septum, deep in the orbit, is extremely dangerous because of the risk of spread to the cranial cavity.
Finally, for this section, let's detail the lacrimal apparatus, the self-cleaning, self-lubricating system.
This is a complex fluid management system. It produces and distributes lacrimal fluid, which is this watery physiological saline that contains lysozyme, a powerful antibacterial enzyme.
And its job?
Its job is to moisten, lubricate, provide oxygen to the avascular cornea, and wash away irritants.
So where does that journey begin?
It begins in the lacrimal gland, which is tucked superolaterally in the orbit. It secretes the fluid via several ducts right onto the conjunctival sac.
And blinking spreads it around?
Blinking distributes this fluid across the eyeball.
And the drainage?
Well, the fluid collects medially in what's called the lacrimal lake. It's drawn into these tiny openings called lacrimal puncta, which lead into the lacrimal canaliculi.
Okay.
These drain into the lacrimal sac, which is the dilated upper part of the nasal lacrimal duct. And finally, the duct conveys the fluid inferiorly, emptying it beneath the inferior nasal concha into the inferior nasal meatus of the nasal cavity.
Which explains why we sniffle when we cry.
Exactly. The tears are draining directly into your nose. What's really fascinating here is the eyeball itself. It isn't just a sphere, it's a specialized optical device encased in 3 distinct concentric layers, and each one is perfectly optimized for optics, protection, and sensory reception.
Starting externally, we have the fibrous layer, the tough outer shell.
This layer is bifurcated functionally. Posteriorly, you have the sclera. That's the opaque, tough, white outer coat covering the posterior 5/6 of the globe. It provides the structural integrity.
Then anteriorly.
Anteriorly, we have the cornea, which is completely transparent and covers the anterior 1/6.
And the cornea is the true optical powerhouse of the eye.
Absolutely. It is the most powerful refractive medium. It accounts for the bulk of the light bending, or refraction, before light even gets to the lens. Its clarity and its smooth curvature are absolutely vital for sight.
Moving inward, we find the vascular layer, or the uvea, which is rich with blood and pigment.
All right, this layer is composed of 3 parts. The choroid is the reddish-brown layer situated between the sclera and the retina, and it's packed with vessels that supply the outer retina.
And anteriorly.
Anteriorly, we find the ciliary body and the iris.
How does the ciliary body work as the eye's focus adjuster?
Well, it contains the ciliary muscle, which is a ring of smooth muscle. When we look at something close up, that muscle contracts. This releases the tension on the suspensory ligaments that are attached to the lens.
And that lets the lens change shape.
Exactly. It allows the lens, which is naturally elastic, to bulge, increasing its refractive power. This active focusing mechanism is what we call accommodation.
And the iris acts as the adjustable diaphragm, controlling the light entry.
It regulates pupil size using 2 involuntary smooth muscles. You've got the sphincter pupillae, which is parasympathetically innervated and constricts the pupil, and the dilator pupillae, which is sympathetically innervated and widens the pupil.
A constant balancing act.
It's a balance between the need for sensitivity in low light and the need for optical clarity in bright light.
The innermost layer, the retina, is the biological film where light is converted into neural signals.
The retina is functionally split into 2 parts. You have the posterior optic part, which contains the specialized photoreceptors and is light sensitive. And then you have the anterior non-visual part, which is just a pigmented layer covering the ciliary body and the posterior surface of the iris. The key to vision, of course, lies in the optic part.
When a physician looks into the eye with an ophthalmoscope, they're examining the fundus. What are the 2 most crucial features they see there?
So the ocular fundus is the posterior anterior surface. The 2 dominant features are the optic disc and the macula. The optic disc is that circular area where the sensory fibers of CH.8 and the central retinal artery and vein enter and exit the eyeball.
And why is it clinically termed the blind spot?
Because it contains 0 photoreceptors. No rods, no cones, so no light reception at that spot. Clinically, though, it's crucial for a different reason. Its margins should be sharp and clear.
And if they're not?
If intracranial pressure increases, say due to a tumor or a massive hemorrhage, that pressure gets transmitted along the optic nerve sheath, and it causes the optic disc to swell and blur. This condition, papilledema, is a key diagnostic sign of elevated intracranial pressure.
That immediately links internal brain pathology to external visual signs. What about the macula?
The macula is situated centrally at the posterior pole. It appears slightly darker than the surrounding retina, and it's the area that's specialized for high acuity, detailed central vision.
And the fovea is right in the middle of that.
Right in the center is the fovea centralis, which contains only cones and is the point of sharpest vision. Damage or degeneration here, like in macular degeneration, destroys that central vision, while peripheral vision might remain relatively intact.
And just circling back to the blood supply, we have to reiterate the issue of the end arteries supplying the inner retina.
It really bears repeating. The branches of the central retinal artery are end arteries. They don't form anastomosis. So if a thrombus, maybe from an atherosclerotic plaque in the internal carotid, blocks that central retinal artery,
It's game over for that tissue.
the result is instantaneous, irreversible blindness. That tissue cannot be salvaged by collateral blood flow. It really highlights the zero-tolerance nature of the brains and the retina's vascular architecture.
So we've established the structure. Now let's talk about the process of sight. Light has to pass through 4 transparent media before it even hits the retina.
Right, this sequence of transparent light-bending media is absolutely essential for focusing. They are, first, the cornea, which does the heavy lifting on refraction.
You talked about that.
Second, the aqueous humor, which is the clear fluid filling the anterior segment between the cornea and the lens. Third is the lens itself. And finally, the vitreous humor, that large, fixed volume of gel filling the posterior segment.
The lens provides the variable focus mechanism accommodation. How precisely does that muscle action translate into focusing power?
Think of the lens as a smart lens. When you're looking at something far away, your ciliary muscle is relaxed. This keeps the tension high on the suspensory ligaments, which stretches the lens thin. Then when you shift your gaze to a book right in front of you, the ciliary muscle contracts, and that instantly relaxes that tension. The lens's natural elasticity allows it to spring into a thicker, more convex shape, sharply increasing its refractive power to bring that near object into focus.
This mechanism is why reading vision deteriorates with age. The lens loses its elasticity.
Precisely. That loss of elasticity is known as presbyopia. It means the ciliary muscle can contract all it wants, but the lens just can't bulge sufficiently to focus on near objects anymore.
So once that light is perfectly focused, we rely on 7 intricate extraocular muscles to make sure both eyes are pointing at the exact same spot. What are these 7 muscles?
We have the levator palpebrae superioris, which raises the upper eyelid, and then we have 6 muscles for the globe itself. The superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, and inferior oblique. And they position the eyeballs on multiple axes.
The movements are really complex. Elevation, depression, adduction, abduction, even rotation. It seems chaotic to try and isolate them.
It is complex. It's because the muscles rarely act in isolation from the primary position, which is gazing straight ahead.
Yeah.
They work in synergistic and antagonistic groups.
Okay.
The complexity really arises because the vertical recti and the oblique muscles have their primary actions only when the eye is already turned medially or laterally, respectively.
So how do we test the core functions simply?
The 2 easiest movements to test are pure adduction and abduction, starting from that primary position. The lateral rectus performs abduction, pulling the eye outward, and it's supplied by cranial nerve 6, the abductus nerve.
And induction.
The medial rectus performs adduction, pulling the eye inward, and it's supplied by cranial nerve 3, the oculomotor nerve. These are really the only pure movements from the primary position. All other vertical movements require cooperation and complex alignment to determine which muscle is deficient.
And when both eyes move together to look in one direction, say you look far to the right, how do they coordinate?
They act as yoke muscles. When you look to the right, the lateral rectus of your right eye and the medial rectus of your left eye are working together synergistically. The ability to smoothly coordinate these movements is essential to prevent diplopia, or double vision. The entire system is totally dependent on intact cranial nerve function. And that raises the single most important question in orbital anatomy. What happens when the nerves controlling this incredibly delicate, coordinated system are compromised? The orbital region is just a hotbed for clinical pathology that stems from nerve damage.
Okay, so let's quickly catalog the 5 main cranial nerves that enter the orbit before we talk about the fallout of their failure.
Right. So CN2, the optic nerve, handles the specialized sensory function for vision. CNV1, the ophthalmic nerve, is purely sensory. It supplies all the orbital contents, including the cornea and the skin around the eyes, via branches like the frontal and lacrimal nerves.
And then we have the 3 primary motor nerves.
CN3, the oculomotor, CN4, the trochlear, and CNC, the abducens suit.
Can you detail the dual function of CN3?
CN3 is the workhorse. It provides somatic motor innervation to the superior, inferior, and medial rectus muscles and the inferior oblique. But critically, it also carries presynaptic parasympathetic fibers that synapse in the ciliary ganglia.
And postsynaptically.
Postsynaptically, these fibers innervate the ciliary body for accommodation,
Right.
and the sphincter pupillae for pupil constriction.
Yeah, and CNIV and 6.
CNIV is exclusively motor to the superior oblique muscle, and CNV is exclusively motor to the lateral rectus muscle. Their long, winding paths make them particularly susceptible to trauma and compression.
Okay, let's jump back to trauma. We discussed the mechanism of orbital fractures, the blowout fractures. Beyond the risk of sinus infection, what are the two main acute consequences for the patient?
First is intraorbital bleeding and inflammation. If that's severe enough, the volume increase can cause exophthalmos, which is the protrusion or bulging of the eyeball. Second, and often more debilitating, is the mechanical restriction. When the inferior rectus muscle gets trapped in the fractured maxillary sinus roof, the patient suffers mechanical restriction of eye movement, and that results in vertical diplopia, especially when they're attempting to gaze upward.
Let's move to the most dramatic failures. Orbital nerve palsies, starting with a CN3 palsy, which is the most comprehensive loss of function.
A complete CN3 palsy is instantly recognizable. Because most of the extraocular muscles are out of commission, the eye is left in the position dictated by the only two intact muscles: the lateral rectus, which is CN3, and the superior oblique, which is CN the ray.
And what position is that?
This results in the eye resting in a permanent position of down and out. It's depressed and abducted.
And what about the eyelids and the pupil?
Well, due to paralysis of the levator palpebrae superioris muscle, which is also CN3, the patient presents with severe ptosis, or drooping of the upper eyelid. And critically, because the parasympathetic fibers to the sphincter pupillae are lost, the sympathetic input to the dilator pupillae acts unopposed. This causes the pupil to be fixed and dilated.
I understand that the pupillary dilation aspect is often the key initial sign if CN3 is being compressed by something like an expanding aneurysm.
That is absolutely correct. The pupillary fibers are superficial in the nerve sheath. So an expanding mass, like a posterior communicating artery aneurysm, typically compresses those superficial pupillary fibers first.
So you see a change in the pupil before the eye movement is affected.
Exactly. You see slowness of the pupillary response to light before the eye movement muscles are severely affected. This pupillary involvement is a massive warning sign.
Moving on to CNIV palsy affecting the superior oblique. This one is notoriously subtle.
It is subtle, and patients often try to compensate. Since the superior oblique primarily intorts and depresses the eye, especially when the eye is adducted, an injury causes the inability to look down when the eye is directed inward.
So they'll have double vision.
They often suffer from vertical diplopia, and they compensate by tilting their head away from the affected side to try and fuse the image.
Finally, CNVI palsy affecting the lateral rectus.
This is a straightforward paralysis of the lateral rectus. The eye fails to move laterally to abduct. The unopposed medial rectus pulls the eye inward, causing a medial strabismus.
And that's horizontal double vision.
The patient experiences horizontal diplopia, which is worse when they're attempting to gaze toward the paralyzed side. CNVI is particularly vulnerable because it has the longest subarachnoid course, and it traverses the center of the cavernous sinus, making it susceptible to anything that causes increased intracranial pressure or internal compression within that sinus.
You mentioned the cavernous sinus, and that leads us to that critical connection point: the danger triangle of the face and the risk of thrombophlebitis.
This connection is a classic clinical reminder about facial venous drainage. Infections on the upper lip, the nose, or the medial campus, the so-called danger triangle, can lead to localized inflammation and infected clots, or septic thrombosis.
And because the facial veins often lack valves.
Because they lack valves, these infected clots can reverse flow and travel up through the superior ophthalmic vein, draining directly into the cavernous sinus.
So an abscess, maybe from aggressively squeezing a pimple, could lead to a life-threatening intracranial infection.
Precisely. Once the septic thrombosis is established in the cavernous sinus, it causes severe headache, fever, and a rapid onset of ophthalmoplegia paralysis of eye movements. CNIV is the first to be compromised because it runs freely through the center of the sinus.
But eventually the others are affected too.
Eventually, CN3, CNIV, and the sensory branches V1 and V2 embedded in the lateral wall will also be affected, potentially leading to acute meningitis and death. It demonstrates the devastating consequences of simple anatomy: the lack of venous valves, when combined with infection.
And let's just tie that back to the pupillary light reflex one last time, as it's the gold standard for testing this cranial nerve integrity.
Right. The reflex arc is CN2 in, CN3 out. When light shines in, CN2 senses it, that's the afferent limb, and signals the brain. The brain then sends the constriction signal back out via CN3, the efferent limb.
So if CN3 is damaged.
If CN3 is damaged, like in cavernous sinus thrombosis or aneurysm compression, the light is sensed, but the pupil cannot constrict. It just remains dilated due to the unopposed sympathetic dilator muscle. Testing this reflex gives us immediate, non-invasive insight into the health of the midbrain circuitry.
That truly highlights how the delicate anatomical relationships in the cranium and orbit create a system where structure equals vulnerability. We have covered the brain's multi-layered defense systems, the circulation architecture, and the beautiful yet fragile sensory machinery of the eye and its associated motor control.
Indeed. We detail the importance of the dura and its relationship to life-threatening epidural hematomas at the pituitarian, the continuous need for CSF regulation, and the reliance on the imperfect but essential collateral circulation provided by the circle of Willis.
And then we saw how a simple blunt force can result in a devastating blowout fracture, and how these tiny nerves, CN3, 4, and 5, determine the position, movement, and function of the eye,
with their failure resulting in these dramatic clinical signs like down and out.
As a provocative thought to leave you with, consider how the complex, often tortuous path of other cranial nerves, such as the facial nerve, CN7, through the bony facial canal and the dense temporal bone makes it so vulnerable. This bony enclosure means that when a common viral infection causes inflammation and swelling of the nerve has nowhere to expand. This inevitable compression is often the direct cause of the paralysis of facial expression muscles seen in Bell's palsy, illustrating that bony confinement, while protective from external force, can be a major liability for nervous tissue when internal inflammation strikes.
A fascinating concept. That the architecture designed for protection can ultimately become the agent of compression and failure when internal pressures rise.
Next time on Bookfulness, we'll be moving on to explore the regions of mastication and the oral cavity, moving on to the structures responsible for chewing, tasting, and articulation.
We look forward to delving into that fascinating region with you.
Thanks for listening to Bookfulness.